Hi, everyone, and welcome to the Q&A session for Fit for Fellowship, a survival guide for the first-year general cardiology fellow. I'm Megan.
I'm Stacy. And today we are very lucky to have Dr. Nigel Gupta from Kaiser Permanente, Los Angeles. Dr. Gupta gave us his talk about ablation complications. And so he is here today to answer all of your questions. Dr. Gupta, thank you so much for being here and for joining us and for this amazing lecture.
No, it's my pleasure. Once again, I think this is a fantastic idea. I was once a first-year fellow, and I hope you found not just my lecture, but all the lectures beneficial. I actually went back and looked at it briefly and realized, as usual, I talk very fast and try to sandwich in a lot of information. So if I am not clear with your questions now, and if you have more questions down the road, Stacy and Megan can always connect you with me. So I hope you find it beneficial. Thanks for the invite.
Of course, of course.
All right, let's dive first into the first question. So the question is, for pacer-induced perforations, are there any risk factors which predispose a patient to perforation?
That's a great question. We tend to discuss this before we implant, and I don't know if it's well published, but definitely older women, thinner tissue type patients tend, in our experience, to be the higher risk for perforation. Kind of when we're operating and we see really thin skin, we just make that analogy that that could be a patient type characteristics. I would have to Google it and look and see if there's ever been anyone who's done a retrospective look. Our incidence is so low here that we haven't really noticed that big a trend, except that more often it's technical that is a higher risk, not necessarily the patient. So obviously a screw-in lead versus a passive lead, putting it at the apex rather than the septum. Some people think if you have a patient with a lot of high PA pressures, that can actually lead to dislodgement because you have TR, but then you're trying to screw it in even, more so during the implant. So that can lead to a perforation. But I think that's a great question, and something that maybe we need to look at in deeper detail. But definitely the feeling around here is when you have someone who's a little older, more frail in general, that their cardiac tissue might be the same way. If they had an apical infarct, maybe you want to stay away from those areas, that type of thing.
Great, thank you. So the second question is, this fellow says, I have seen some physicians give a course of antibiotics to patients after pacemaker placement. Yeah. Is that routinely done? And if not, what are indications to do so? As a fellow, should we ever prescribe antibiotics to patients over the phone if a patient calls with concern for pacemaker infection versus have the patient go into the emergency department to get evaluated?
Those are great questions. Again, just last night we were doing a case and we were sending the patient home, and the question was, do we give them antibiotics? This was published or discussed at Heart Rhythm a couple of years ago as a late-breaking clinical trial, and it is very well established that the most important dose, and it does work, is the antibiotics before implant. It is highly debatable and not highly evidence-based to use it afterwards, prophylactically. Having said that, we do it sometimes, either as an inpatient, 2 doses IV afterwards. Last night, in fact, in my order set, my infectious disease doctors removed it from my order set. So I feel okay not giving prophylactic antibiotics afterwards, especially a new implant. Half my docs do it for gem changes, half don't do it. So not urgent. Okay. Your second question is a really important one. If we get a call for a bronchitis or things like that, we feel comfortable giving antibiotics over the phone. I think if you have a patient with any concern for an infection on a device, it's probably more important to bring them in. The reason being is that if it is an infection, oral antibiotics probably aren't going to take care of it. And unless there's very rare superficial cellulitis, which is the only thing sometimes you can treat through, but you might as well draw blood cultures first. You don't want to miss something deeper because those can become systemic quickly. So I would say in general, it's not good practice to give oral antibiotics over the phone without seeing the patient. Now, we've done it if we think it could be a cellulitis, because the patient also sends you a picture in this day and age of EMR and virtual visits. They can send us a picture in our email on the EMR. So I've maybe had a case where it looked like superficial cellulitis and I felt comfortable with it and then done it. But I think as a first year fellow, be careful, or as a general cardiology fellow, low threshold to bring in someone you're concerned about an infection.
Absolutely.
Excellent. The next question is, how often after ablation does a patient develop heart failure or symptoms of volume overload? If so, how long do I treat them with diuretics?
That's a very good question. Out of all the types of ablation we do, the ones that we do that are more common SVTs, like atrial flutter, AV bypass tracts, it's very rare. They shouldn't unless they already had an underlying condition. And so that would be highly suspicious. What is more common and related to the procedure are radiofrequency ablations for atrial fibrillation, because we actually use irrigation at the tip of our catheter. So a patient can get a liter or two of fluids just from a long procedure with a lot of ablation. And we actually learned that the hard way. We had started sending patients home same day after an AFib ablation, and the few that bounced back were from heart failure. The duration for which you want to diurese them, basically, most of them get better, after a day or two. But every patient is different, as you know, for diuresis. And a patient who has had an AFib ablation, especially if it's radiofrequency, you can write it off to that if they got a lot of fluid. But if someone has heart failure from an ablation otherwise, with not a lot of radiofrequency and not a lot of fluid, you should be sure that you're not missing something else. Cryoablation, for example, doesn't use a lot of irrigation, so it shouldn't be from that. And then, even though we're not, a Watchman procedure or a left atrial appendage procedure, sometimes we bolus them. Like I give patients a liter of fluid to open up the appendage to measure it. So that has, put people into failure. Those are the things I think about. And the only other thing to think about is some patients get contrast. So they could go into renal failure from that, especially from a cryoablation or a left atrial appendage procedure.
Oh, excellent. Thank you.
Okay. Next question. So if a patient reports chest discomfort just a few days after ablation, is that something you would just watch, or would you prescribe something for pericarditis immediately, like colchicine? And this is assuming that the patient does not have ACS.
Great. No. And again, I think do a quick chart review and see what kind of ablation it is. We almost never see it, chest pain, unless it is an atrial fibrillation ablation. And you can rest a little easy with an AFib ablation, meaning like, okay, that's what they intended to do, and that's good ablation because they got pericarditis. Some of my attendings actually empirically give colchicine, and I don't, because of the side effects that you probably know more from your medicine residency, the GI side effects. So what I would say is, if it's AFib and there's no other warning signs, meaning pericarditis can also be blood in the pericardium, right? Not just irritation, and it could be a slow bleed. So low threshold to make sure there's no other major warning signs, an EKG, and maybe, you guys are great at this now. I mean, I think the patient should just be looked at sooner than later, and a quick bedside echo. If those are okay, colchicine is fine. If it is a patient who has not had an AFib ablation, then definitely bring them in to look at them first with a quick bedside echo, because and a differential diagnosis for pleuritic chest pain, like a PE or something else, because it is not common or expected to have pericarditis pain from normal AVNRT, atrial flutter, bypass tract. Even VT ablations to burn that thick is really hard. An AFib ablation and cryo, if everything looks okay, you feel comfortable, go ahead and give the colchicine, but you might want to do a quick exam, a quick what do you guys call them? Point of care ultrasound bedside. I can't do those, so I call the general. I would call you for help on that. You guys are better at that than me. So
Excellent.
Thank you.
The last question is, after an atrial fibrillation ablation, Up to how long afterwards should I expect that the patient might have runs of atrial fibrillation?
Oh,
How should I treat those patients?
yeah. So, per the Heart Rhythm Society, atrial fibrillation for up to 3 months afterwards is not considered a failure. So, I guess that means they're allowed to have it for 3 months afterwards. In all honesty, if we get good pulmonary vein isolation, most of our patients do pretty well. But I often will stop the antiarrhythmics afterwards. Some of my partners will continue it for that 3-month blanking period. So what I would say is if the attending who did the procedure, that the team did not continue the antiarrhythmics and they have AFib right after, put them on an antiarrhythmic for that 3-month period, let the scar tissue heal, and then you can stop it and reassess. The reason why some patients may have more than others is that if they actually did a lot of burn and then they have true pericarditis, that's actually a good thing. You don't want to attribute that to the blame that for the AFib as a failure, then you can give them the antiarrhythmic. So long answer, short. If they have AFib after, we recommend, hey, resume the antiarrhythmics for 3 months and then let's see how things go.
Perfect.
Excellent. Well, thank you very much for that.
Thank you.
Sure.
Yeah, thank you so much for being here and giving us a lecture and answering everyone's questions.
Yeah, no problem. I'm surprised there's not more questions on the crazy PMT algorithms and things like that. Those might be for down the road. So happy to answer those if people dive into them later.
Of course. And thank you again for the presentation. And we'll
Sure.
definitely send more questions as we
No.
get them.
My pleasure. Anytime. Good luck, everyone.